Okay, I haven't done a live in forever, so hopefully this actually works. So I got asked a question about if I could give tips for chronic plantar fascia pain. And I want to help, but the thing is, if you want to solve your plantar fascia pain, well, first of all, you need to make sure it's not something else misdiagnosed. But if you really want to solve your plantar fascia pain, you need to get to the root cause of your plantar fascia pain as an individual, considering all of your contextual factors outside of you, like your loading, your movement patterns, your intrinsic system, and what's going on inside your body as well, because there's going to be many factors depending on the individual that's going to affect like what's driving, the body is a great machine, and what's driving your plantar fascia to be the weak link in the chain that's complaining, right? Like, why has plantar fascia gotten a problem and not everywhere else in your body, and there's a number of potential reasons for that. So I've got my texters because I thought, I'm going to have to write a huge list of stuff, and we're going to go in all different directions. So the first thing we do, the standard physio approach, the first thing we do is we take a thorough history. And so in that history, we need to also see, was there a previous history of other injuries that might be why and when we then screen your movement patterns, then we might be looking for any compensations, or are you overloading the plantar fascia because you're trying to protect something else? And that's where your coaching eye comes in as well, which a lot of physios don't have, but hopefully any good physio that you might see would have a good coaching eye to be able to see that you're compensating for, or that plantar fascia is potentially being overloaded because you're using that, say it's your right plantar fascia, that you're using that right leg more, or something to that similar effect. So let's just first of all talk about, there's so many things we could talk about. Okay, let's start at the start. So your plantar fascia, so let's say this is a foot. Yes, I know. Okay, from your calcaneus bone, your plantar fascia comes up and has all little attachments like this, and to the muscles as well. Okay, so that's your plantar fascia. Hang on, it joins a little bit more towards the inside, not so much the outside. Okay, so most often people will experience pain around about here, but you can also experience pain through the middle as well. I just realised you can't see my drawing. Can you? I don't know if you can or not. Oh well. I move that across. Maybe you can see. Or maybe you can see. There's just writing in the way. Okay, good. All right. So the other thing to consider is, so say this is a leg and your foot. Your gastrocnemius, which is one of your calf muscles, comes down, joins into an Achilles tendon here, joins into the back of the calcaneus bone, calcaneus, whatever. I always pronounce things random ways. Okay, and then from the other side of your calcaneus, your plantar fascia comes here. So, why do we need to think about this? Because if there is too much tension in your calf, it can potentially cause issues in your plantar fascia. Now, this is the stock standard basic thing that you're going to rule out on everyone, right? Are their calves tight? Blah, blah, blah. But you've also got to consider the whole fascia chain of the superficial backline as well. So, which I can show you here. So as you can see, there's connections all the way from the bottom of the foot, all the way up It actually even comes over to the front of the head here. So you want to check that. If you think it's just an overload thing or an overuse thing, well, first of all, you got to check load management as well. So when you take a good history, right, you're going to look at previous medical history. You're going to look at the loading history leading up to it happen. So have they had a sudden increase in load? Let's start making a list. We've got to make a list, guys. So previous medical history, loading, which is going to take us to load management as part of the treatment. So their loading history, okay, as to why they might have overloaded it. And what else are we going to look at in the history? What's their sport? What have they got coming up? You know, all that sort of stuff. Medical conditions, because quite often, I'll often see plantar fascia randomly coming on in women who have no reason, like they haven't had any loading reason for this to occur, but they're going through perimenopause or menopause, so hormonal changes, and or recently diagnosed with thyroid conditions or recently started thyroid medications. Another thing is if people have been on antibiotics, that can set off tendon and or plantar fascia things as well. So a thorough medical history is good too. I realise you can't read my writing, so maybe I won't write a summary. So anyway, someone comes in. The first thing that a normal physio will, ask all those questions, get a thorough history. Then when we go to the physical assessment, we've got to see what's not doing its job. Are you compensating somewhere else? Like look at movement patterns, squat, lunge, running, your specific activity that you're having problems with. We're going to look at your walking, because the calf is also a part of the whole posterior chain. So when you think about when you take a step, your glute, hamstring, and your calf and your Achilles should all be working together. And if they're not, sometimes people can like overuse the calf and the ankle complex, and so they'll be really calf and foot dominant in their movements, as opposed to using the whole glute and hamstring and the whole posterior chain. So you can see that by doing a walking assessment. You can confirm that then by doing individual hamstring, glute, calf assessments. So anyone who walks through the door with plantar fascia, any good physio is going to check your calf strength and endurance, your foot intrinsic muscle strength, your strength of your flexor hallucis longus, which is the muscle that pulls down the big toe, the flexor digitorum longus, the one that pulls down the outer four toes, and prescribe exercises for any of these. We'll also check that the calf muscle, because of this relationship here between the calf, the Achilles, and the plantar fascia, also check the calves aren't tight, loosen the calves, wham bam, and loosen the plantar fascia. That's standard physio approach. If there's any weaknesses, obviously prescribe, various types of calf raises and or hamstring strengthening, whether it's hamstring bridges, glute bridges, whatever. Now, if that standard approach doesn't work, or they can't activate the muscles, or it's still, when they get up to walk, it's still not integrating. It could be a motor patterning issue, and so maybe you can use cueing to correct that. If they can't activate the muscles, sometimes it can be due to sometimes if you have any stickiness or any points of adhesion or compression along the entire fascia chain of the back line, not just the superficial backline anatomy trains. I'm going to another fascia training in my mind now, where there's centers of coordination along the posterior fascia. And so fascia is really richly innervated with a lot of proprioceptive nerve endings that can send a lot of pain signals and proprioceptive information to the brain about where the body is in space at any moment in time. And so all subconsciously, there's all these messages coming to the brain, which actually affect which motor patterns and premotor cortex patterns that your brain then sends out and it's happy to activate. So That's why sometimes you can have difficulty activating a hamstring at all, and then simply by working a few fascia points, all of a sudden the strength is suddenly that much stronger. Like, that's not a gain in strength, that's a gain in neuromuscular activation, which could have been because it was inhibited because of some form of fascial tension or perceived threat by the nervous system. So this is where I veer off, and I'm a bit rogue from a normal physio because of my own experiences. And sometimes I was doing the rehab and movement execution absolutely to a T, and like smashing the rehab, doing my movements perfectly. And sometimes I'd be like, I just cannot get that muscle to switch on. And sometimes once I started learning about fascia and the centers of coordination model of the fascia and that sort of thing, it helped with me to clear some ongoing pain, or even when there wasn't pain, I didn't even realize it was tight and restricting me from moving with some of my injuries. And then also I started to use it on patients as well once I was happy after a few years of, okay, this isn't woo bullshit. Like, there's neuroscience behind it. There's science behind this. So the other thing is that sometimes if the line, so say we're looking at the back line. So let's say we're looking at this back line, for example. If you've treated that and there's still an issue with activation, sometimes you actually need to treat the opposing line, which would be the front line. So you can see where that would work, right? Like if someone's stuck down from the front, it's going to be harder for them to use their back line and stand up straight. So we've gone down a rabbit hole. So these are all the things that are going around in my head. And normally when a patient comes in, we're not going to go into all these different directions, because if you take a good history, it's going to give me, if I take a good history, it's going to give me clues straight away. What is their pain related to? Is it a loading problem? Is it a fascia problem? Is it a motor patterning issue? Is it a training load issue? Is it a hormonal medical related issue? Is it just a whole system overload stress issue? And I need to do, that's the other thing I do, it's a bit outside the box, like a vagus nerve support or nervous system support, heart coherence, stuff to bring the system into more balance so that it can heal itself, looking at stress and lifestyle factors, sleep, nutrition, etc. So the history taking with the patient is going to give me a lot of clues as to what I'm going to then assess in the physical assessment. Speaking of physical assessment, anything below the lumbar spine, any injury below the lumbar spine, you always have to screen the lumbar spine to make sure there's not neural involvement or neural inhibition. So I also would screen the lumbar spine. The other thing is you need to look at your differential diagnoses as well. Like, is this actually plantar fascia pain? And confirm that before you, because it's very easy to look at pain in that area and go, oh yeah, it's plantar fascia. But it could also be medial plantar nerve entrapment. So there's a nerve that comes down through the inside of the ankle and exits under the foot there, and it can cause pain exactly like plantar fascia pain if there's entrapment of that nerve. Or it could be from the lumbar spine, a radicular pain. So you've got to screen, but the history is going to give you clues about that as well. So you've got to screen the lumbar spine, rule out differential diagnoses as well. So what else was I thinking? The other thing is that, and this is going, if, doing the muscle strengthening hasn't worked, fixing the motor patterning hasn't worked, assessing the fascia, releasing the fascia, and the centers of coordination of the fascia hasn't worked, then I'm going to go into my other new toolbox, which is the functional neurohealth stuff, which is if potentially their primitive reflexes have been reactivated, like have they had a recent concussion or something like that that might have set off their reflexes, or a cranial nerve issue or other issues that are affecting the way that their motor patterning and their loading. Is there a vestibular issue? Is there something that's affecting the way that they're moving and or inhibiting certain muscles? So certain primitive reflexes, which should all be integrated by the time you get to adulthood, if they are reactivated, it can actually cause inhibition patterns of certain muscles and like a lack of, and that occurs via the brain sending messages to certain muscles, like not being happy to send activation to certain muscles and or over facilitating other certain muscles. So then we can do corrections for that as well. Now, so like I was saying, there's like, you know, your standard, just look at the spot, like your probably average physio, like just look at the calf and the plantar fascia. There's your better physio that's gonna, you know, screen the lumbar spine and look at the whole posterior chain and biomechanically coaching eye. There's your bit outside the box physio, which is going to go into the fascia stuff. There's even more outside the box into the fascia centers of coordination. And then there's into the different neurovestibular coordination patterns, primitive reflexes, you know, the box. If all of that still hasn't worked, I'm going to look at your meridians and go into some traditional Chinese medicine stuff with your acupuncture lines and things like that. And there's certain organs that are associated with certain muscles. There's also a connection between the diaphragm and the calves. So I might even treat your diaphragm or do a phrenic nerve release. The phrenic nerve innervates the diaphragm. And look at, in traditional Chinese medicine, there's emotions associated with different organs, and there's various subconscious emotional processes that we can do to process those. Now, this is well outside the box, and I probably wouldn't do this in a physio session. I would do this as a separate session under the functional neurohealth umbrella. So, because it's well outside the box of normal physio. But yeah, so these are all the things that you've got to consider. Even within like all those things that I've talked about, like load management, like there's lots of we could do a whole mind map of each of those areas and what various exercises and that sort of thing. So there's just, the point of all this was to say, you know, any injury in any individual, it's not textbook, it's not cookie cutter. There's a lot of physios that are textbook and cookie cutter. And because of my own experiences, I cannot be textbook or cookie cutter. So because I had to go well outside the box for my answers a lot of the time when I was doing everything to a T of my training and research papers and evidence-based. And sometimes I still didn't find the answers. And so that's when I started looking at initially more whole system health from that Western medicine perspective of, you know, checking hormones and, you know, hormone panel, sleep, nutrition, diet, you know, monitoring my sleep, heart rate variability with the URA, stuff like that. And then I still was struggling, found a physio that did the fascia work and stuff like that, and found that really helped, you know, to fill a few gaps. And then I was still searching for other stuff, and why I would just get these recurring patterns of just certain muscles not working, and it could be triggered by certain things, and, you know, it could be reflexes reactivated or cranial nerves not functioning correctly. And especially I'd had a Bell's palsy in my face when I had shingles in my face, like I've had concussions, things like that. So when it's like a little bit outside the box, or if it's an athlete who's having like a bunch of like injuries nonstop, just abnormally, and it's not a systemic biochemical issue, like you've ruled out all that stuff, you know, you've ruled out. Well, this is the other thing. There's so many things you need to look at. Like, if they're having lots of fascia issues, you've got to look at their detox pathways, like, because, you know, if they're getting too much exposure to mold, you know, pesticides, any sort of toxins or things like that, that's going to affect their fascia's ability to move and glide as well. The other thing is that there is evidence coming out that emotions affect the fascia. There's the whole quantum biology world of, you know, EMFs affecting fascia, and EZ water. So there's water that lines your fascia, and that, you know, electrical... Okay, I'm going really outside the box now. So if you go into the you know what, I think quantum biology is a discussion for another day. So if you have questions about that, let me know. But we did the stock standard physio approach to plantar fascia. We talked about fascia approach to plantar fascia. We talked about load management. And so usually it's like some form of sudden increase in load. If it's not the sudden increase in load, it's maybe a decreased capacity to handle load because you're not supporting your system with enough nutrition, stress, sleep. And you may unintentionally be in relative energy deficiency syndrome or something like that. What else did we talk about? Strengthening the local muscles, motor patterning, whole posterior chain, use your coaching eye. We talked about checking the neurological, like if those muscles are actually inhibited neurologically because reflexes or cranial nerves might be like just not quite right signaling going on. So, and what else did we talk about? Oh yeah, meridians, traditional Chinese medicine approach. Yep, then we went into the emotions and that sort of thing, which is too out there for some people. So definitely that's you know, that's what some people need. So and or vagus nerve support as well, and diaphragm support, just because of that link between the calves and the diaphragm. So it's probably more that I've forgotten to mention, but I hope this was informative. You know, it's probably 15 years of obsessive research and rabbit holes and going outside the box, just applied to one little situation. So yeah, I'll post this, and I don't care anymore if people think, you know, if I lose credibility because of this outside the box stuff, because there's people who need answers to their problems and they're not going to find it within traditional methods. So I'm sharing it for those who so just in case, so it doesn't take them 15 years and endless money and hours of research to find it. So yeah, any questions, let me know. Thanks Joey. Sorry, I forgot to talk to everyone, as this is the first time I've done a live like this. So I'll post it so you guys can have a look, and if you have any questions, feel free to. I'm looking at myself. This is what I'm so awkward. I'm like looking at myself in the camera instead of looking like in the camera. Anyway, so thank you, Joey. Jo's a really amazing practitioner as well. I highly recommend her if you see her in the comments there. Yeah. All right, see you guys. Hopefully this saves. Oh my God. Can you imagine?